and welcome to our webinar, which is on the Introduction to Genetic Testing in Ophthalmology. My name is Dr. Mohanish Suri. I am a consultant and clinical geneticist, and together with my colleague, Ashlyn Cooper, we will be going through the webinar with you today. So there you can see a snapshot of Ashlyn, who is our senior clinical scientist at the Genseq lab. So the agenda for our webinar today is to talk about the clinical applications of genetic testing for eye disorders and genetic testing pathways. So those two things I will cover, and then I'll pass you along to Ashlyn, who will cover variants overview, whole exome sequencing and workflow overview, gene panel testing overview, the ophthalmology panels that we actually offer through Genseq, variant interpretation and classification overview, and then we've actually got rid of that slide. So so there will be a workflow overview of cascade testing as well. We've got rid of this slide, clinical utility of cascade of familial testing. Then I'll take back the hot seat and talk about complexities of ophthalmic genetics, talk a little bit about genetic heterogeneity with an example of Stargardt, and also to give you some information about phenotypic heterogeneity of eye diseases, again, with the example of APGA4 variants. And then we have 3 case studies to show how you can actually use gene panel testing to get diagnoses for your patients. And then we'll end with a question and answer session. So I hope that's okay. So you can actually make a clinical diagnosis of many eye disorders just by examining your patient. So the question then arises is why should you actually be doing genetic testing? What is so great about genetic testing? Why should you offer it to your patients? So sometimes you may be quite certain of a diagnosis. For example, you know that your patient has retinitis pigmentosa, but you're not entirely sure what the inheritance pattern is, or you think maybe there is something else going on, so you're not entirely sure of the diagnosis. So in those situations, it's very helpful to actually consider genetic testing to confirm your clinical diagnosis. And you'll see here from the statement that whole exome sequencing, whole exome testing has demonstrated very impressive diagnostic yields of 50% plus in inherited retinal disease cohorts. So like I said, this is especially useful when you're thinking about confirming a diagnosis where you're not so sure exactly what your patient has. The second reason you might want to do genetic testing is to provide prognostic information. So obviously, if you've got a molecularly based diagnosis, you can be quite sure about the sort of information that you're going to give to your patient. So for example, if you have a child that has hearing loss from a very young age and then develops some eye features of a retinal dystrophy, if you are then able to do genetic testing and make a diagnosis of Usher syndrome type 1, you know that this child is eventually going to lose sight and lose hearing. So then you need to put into place to stop sensory deprivation of the patient, you need to put into place other things. So that is really, really important to get that diagnosis. You might also want to do genetic testing because you want to see if your patient with a specific eye disorder is eligible for gene therapy or some sort of personalized treatment. And a very good example of that is RPE65-related Leber congenital amaurosis. So if you're able to make that diagnosis, then you can recruit your patient to RPE gene therapy trials. Like I said in the beginning, one of the reasons why you want to do genetic testing is to actually find out what the inheritance pattern is. So there are many examples of genetic disorders, genetic eye disorders, for example, retinitis pigmentosa, that can be inherited in many different ways. So autosomal recessive, autosomal dominant, X-linked, mitochondrial. So to be able to actually provide information about offspring recurrence risk, and if you have an affected child, then sibling recurrence risk, you need to know what is the genetic inheritance pattern of the eye disorder in that family. And in that sort of space, genetic testing can be extremely helpful. And lastly, there are some families who have eye disorders and they've had a child with an eye disorder and they don't want to pass that on to another child. So they might want to be considering prenatal testing or pre-implantation genetic testing. So IVF with pre-implantation genetic testing. And you can only offer those tests if you have a genetic diagnosis for your patient. So those are the reasons why you might consider doing genetic testing for eye disorders. There are 2 broad types of genetic testing that you can do for eye disorders. The first is that you can do a panel test, which links up to the phenotype in your patient. And once you have a diagnosis for your patient, you can then do cascade testing, which means you test people at risk in the family. So here are the two testing pathways. So the pathway on your left here is different from the pathway on your right here, because in this pathway, you haven't identified the diagnosis, the molecular diagnosis, and you are trying to do that. The cascade testing pathway, you can only go into this pathway once you have a molecular diagnosis. So this is reliant on this. So this is the sort of pathway that you would follow. A patient presents with an eye phenotype. You do a detailed clinical assessment, take a history, draw up a family tree, then decide what sort of panel test you want to offer. And there are a wide variety of panels that you can choose from. If you have been able to identify a pathogenic variant, then you can obviously work out the inheritance pattern of that eye condition. You can then refer at-risk family members for cascade screening. You can talk about the possibility of a recurrence of that condition and the tests that you can offer during a pregnancy. You can refer the patient to relevant clinical trials, including gene therapy trials. And you can also start any precision treatment that you might do. For example, if you made a diagnosis of COL2A1 related Stickler syndrome, where there is a very high risk of retinal detachment, you can consider doing something like retinal cryopexy to reduce the risk of that patient actually having retinal detachment. So now you've got your molecular diagnosis in this patient, and you can move on to the cascade testing pathway. So at-risk people in that family, so these are first-degree relatives, so parents, siblings, children, you can refer them on for cascade testing. So here we are doing whole exome sequencing because we are looking at panels. Here we are only looking at just that one pathogenic variant that has been identified in the gene. So we're not doing a whole panel, we're just doing a single test, and that's why we use I'm going to pass you on to Ashlyn for the next slide.
Thank you. We'll just get me up and running here on the slides. There we go. Hopefully that is visible now. Yep. Okay, so I'm going to bring us sort of back to basics a little bit first and talk us through a bit about what variants are, what kind of testing we're doing when we're talking about gene panel testing and cascade testing, and also a little bit about how we analyze and interpret any variants that we find. So first of all, what is a variant? And I think this, a lot of people will have heard them referred to as mutations more sort of generically and historically, but we generally talk about variants now when we're talking about any sort of difference in a person's DNA from what we would consider the reference genome. So there are different types of genetic variation that you might see, and we can break them down sort of broadly into categories. You'll have single nucleotide variants, and that's where there's just a change, either a substitution change, a deletion, or an insertion change of a single nucleotide in our sequence. Copy number variants tend to refer to sort of bigger events, but they are deletions and insertions and duplications of chunks of DNA. And then you've got things like structural variants, so inversions and also translocations of parts of DNA from one position in the genome to another. And we can sort of broadly categorize, and I will talk about how we do this a little bit further on, into sort of classify the variants as benign, uncertain significance, or pathogenic, and that's defining their contribution to disease. And our ophthalmology gene panels analyze a whole exome for pathogenic variants known to cause retinal disorders or other ophthalmology-related diseases, sorry. And then as Manish has gone through before, we cascade testing, we test for the single known pathogenic variant. So I'll talk a bit about what exome sequencing in general is. So we use the next generation sequencing technology to sequence all of the protein coding regions of the gene. And this is what is defined as an exome. So when we talk about whole exome, it's that we're covering all of the protein coding. It's not to say that there isn't useful information in the non-coding regions, but in general, the vast proportion of causative pathogenic variants are in these coding regions. So you are covering a good chunk of what would be considered disease causing by covering the whole exome. It's obviously not totally comprehensive, but it is a very large proportion. So the types of variants that we can identify using this whole exome sequencing are single nucleotide variants, copy number variants, insertions and deletions, and all in those protein coding regions, obviously. And then we can't identify tandem repeats and large structural variants using this technology. So the applications of whole exome sequencing, which we use here, is virtual panel testing, and I'll go into that in a bit more depth next. But it can also be used for trio or singleton testing. So trio is where you're testing the affected individual and both parents, so that you can stratify your variants by inheritance patterns that are seen between the parents and the affected individual. And this is particularly useful when a phenotype is not specific or it's rare disease testing, whereas virtual panel testing is more useful where there is a clinical indication. So just to run through the workflow of whole exome sequencing, we receive blood samples, but we can also receive saliva and buccal. And we extract DNA from these samples using, and we have a very automated workflow here in Genseq, so you can see all these beautiful robotic instruments doing all the work. We extract the DNA, we move on to sequencing library preparation, and then we sequence it. So this produces sequencing data for the whole exome for multiple patients at one time. And then from here, our bioinformatician, who is a magician in my eyes, manages to do QC, alignment, filtering, so processes that data using bioinformatic pipelines. We then apply our virtual, so when we talk about our gene panels, we sequence the whole exome and then we filter for the genes that we have defined in those gene panels. And then we perform variant assessment on any variants that are found within those genes. So what is a gene panel essentially? It's a group of genes that are associated with a specific clinical indication. And by performing these gene panels, we're testing for multiple genes simultaneously, rather than just targeted single gene by single gene analysis. We curate and develop these gene panels using online resources that look at the association between genes and clinical indications or phenotypes, things such as PanelApp, which is a UK-based one, and ClinGen, and US-based. And these are curated by experts. So, and the disease gene associations are readily available there, and we assess those and periodically update our gene panel content. The genes obviously are associated with the disease, and there's known pathogenic variants within those that are associated with the clinical indication. We develop these panels for either very specific indications, or we can do it for broader, more overlapping phenotypes, like Manish was mentioning earlier. And clinicians then can select the most appropriate panel based on their patient's clinical indication. These are a list of our available ophthalmology gene panel tests at the moment. And we have obviously the smaller and medium ones that are more targeted in general. And then we have larger panels for those sort of broader phenotypic spectrum, so retinal disorders as a whole and structural eye disease, where there's more overlap. How do we then, once we've got variants, interpret and classify them? So as I mentioned earlier, we have different sort of classifications: pathogenic and likely pathogenic, uncertain significance, which I will go into a bit more detail about, and benign and likely benign. Previously, it's been a bit inconsistent how labs would have classified variants. Different labs would have classified variants. But in 2015, the ACMG, so the Association of American, it's a medical genomics group in America, basically. I've never got the name down, but they produced a paper, and it's basically the paper which the vast majority of labs now follow, and it's a framework for variant classification. And basically, they've defined different types of evidence, and they've also given us a strength at which these different categories of evidence can be applied. So you've got things like population data. Is the variant present at a high level in the control or normal population, or has it been seen in quite a few affected individuals? You've then got computational and predictive data. So is this variant predicted to have a damaging effect on the protein that the gene produces? Does it truncate it, or does the change of amino acid completely disrupt the function? Adding weight to that is functional data that proves that the function is either disrupted or not. And then you've got case level evidence as well, where maybe we'll see a variant is in a family in all the affected individuals and not seen in unaffected individuals, so that's segregation data, or it might arise in an affected individual and not be present in their two unaffected parents, so that's de novo data. So that's kind of, some of the flavour of the evidence that we'd be looking for. And we find this evidence either in literature searches, so wide functional studies and case studies out there. There's really useful databases now available. ClinVar, which a lot of people are very aware of, is a repository for variants and their significance. And there's a lot of computational tools as well for those predictive data. And even though this paper did allow us to get much more consistency across the field, there's actually been further updates by different groups, ClinGen in the States and ACGS in the UK, which have allowed us to get even more consistency and also just some clarification around some trickier sort of scenarios, and also some more disease and gene specific updates as well, which have really helped. I did mention earlier, there's this large group of variants of uncertain significance, which can cause a lot of confusion for clinicians and patients, because what does it really mean when you have a variant of uncertain significance? It's not giving you a diagnosis. So that can be very difficult then. There might be a risk of an inappropriate diagnosis or treatment off the back of this. And as you can see from this chart on the right here, there's quite a large category in the orange there fall under this variant of uncertain significance. So when do we report these? Because some of them are very close to being benign, some of them are in a very wide area in the middle, and some of them are more close to being likely pathogenic, and there's maybe some evidence that could be gathered there. So we generally only report them, and it's only considered appropriate to report them when there's already a high level of supporting evidence. So they're very close to that likely pathogenic threshold, and that there might be sort of further studies or investigations that could be done to maybe reclassify that as likely pathogenic. It should also be noted that the variant should be in a gene that's associated with the clinical indication before it would be appropriate to report. So once we've found a variant in an affected individual, as Manish said, this allows for possible testing of at-risk family members. So this is what we define as cascade testing. Those family members could be affected or unaffected. If they're unaffected, it's considered predictive. If they're affected, it's considered diagnostic. This, the benefits of cascade testing really allow for early detection. So if it is predictive, we're getting in there before people are even manifesting any clinical indication. And this then allows for increased surveillance or possible treatment, preventative treatment if available. It also allows for informed reproductive decisions. So as Manish alluded to earlier, there could be prenatal testing or pre-implantation genetic testing available. And this is also, it does allow for stratification of therapy. So how do we test for when we're doing cascade testing? We don't need to perform whole exome. That's a very large test, a very broad test. We're looking at all of the whole coding region, and we only want to look for one single variant, known and established variant in these cases. So we use much more targeted rapid testing for this, and it's called Sanger sequencing. So essentially we're amplifying a target, a very specific target, sequencing rapidly just that small fragment, and we can then detect the presence or absence of that familial variant. So again, we start with extraction, and again, it's blood, buccal, and saliva that we can test on. And we amplify the region, do a sequencing reaction on there, and then basically we pull these through small capillaries, and it allows us to see individual bases and call whether there's a change at that sequence or not. So that's a very brief overview of all of those things. I'm going to hand you back to Manish to allow him to go into some of the more complexities of ophthalmic genetics, and also some lovely case studies. So I will stop sharing here.
Right. So ophthalmic genetics is actually pretty complex, and it's complex for many of the reasons that are listed on this slide. So the first sort of thing that you need to consider is penetrance. So what penetrance is telling you is that if you have inherited a genetic variant, do you have any aspect of the phenotype, or are you completely asymptomatic? So if you are completely asymptomatic, then you are incompletely penetrant. In other words, the gene is not penetrating through and manifesting a phenotype. So a very good example of that might be Leber hereditary optic neuropathy. So this is a mitochondrial disorder that is caused by some common variants in mitochondrial ND1, 3, and 6 genes. The penetrance of Leber hereditary optic neuropathy is quite high in males, so around 90%, but not 100%. So 10% of people with LHON who carry an LHON pathogenic variant may not manifest the phenotype. But in females, it's a lot less than that. It's 50% or less. So there's a far higher chance that a male with a LHON pathogenic variant will actually develop the condition than a female with that same variant. So that is incomplete or reduced penetrance. The second concept is expression or variable expression. So what that means is that you can have people with the same variant manifesting phenotypes that are slightly different. And perhaps a very good example is neurofibromatosis type 1, which I'm sure you're all aware of. So you might have one person with neurofibromatosis with lots of brown patches, cafe au lait patches over their skin, and you might have axillary freckling, you might have sphenoid wing dysplasia. But in the same family, another affected individual with NF1 with exactly the same familial NF1 variant may actually have a much more severe phenotype with multiple cafe au lait patches, freckling, axillary freckling, Lish nodules, optic nerve glioma, and sphenoid wing dysplasia and intellectual disability as well. So that is an example of variable expression. Another big problem with ophthalmic genetics is that the genes that cause eye disorders, particularly the retinal dystrophies, this variants in the same gene can give you many different phenotypes. So that is, you can see it's number 5, phenotypic heterogeneity. We'll go back into that in more detail in a minute. But there are very few genes that cause just one specific eye disorder. And I've listed a few here. So retinoschisis, which is an X-linked gene, gives you, so if you have pathogenic variants in RS1, you get this X-linked recessive condition called retinoschisis. It doesn't really cause any other eye phenotype. Similarly, if you have pathogenic variants in CHM, you only ever get choroideremia. You don't get anything else. And if you have variants in ITPR1, then you get just the eye phenotype of Gillespie syndrome. So, but there aren't many genes like that in the sort of list of eye-related genes. Then we have to consider the concept of heterogeneity. So the first concept is genetic heterogeneity, which means that the same disease or clinical condition can be caused by different genetic changes. And this can be of two types. So the first is locus heterogeneity. And a very good example of this is retinitis pigmentosa. So you can have autosomal recessive retinitis pigmentosa that can be caused by variants in some genes. You can have autosomal dominant retinitis pigmentosa, for example, which might be caused by variants in rhodopsin. And then you might have X-linked forms of retinitis pigmentosa that are caused, for example, by variants in RPGR. So these are different genes, but they're causing the same sort of RP-like phenotype. The second concept in genetic heterogeneity is that you have one gene, but in that gene, you may have missense variants, frame shift variants, stop gain variants. They all cause the same or similar sort of eye disorder. So these are the two types of genetic heterogeneity. And then the last concept is about phenotypic heterogeneity, which means that the same changes in the same gene, so it's not the same genetic variant as listed there, it's changes in the same gene can result in different clinical phenotypes. So I've got some examples of those on the following slides. So here's an example of the genetic heterogeneity of Stargardt disease, which is something that the eye team see quite a lot of. So the first point to mention is that there are actually 4 types of Stargardts, but in fact, testing for one of the forms is not currently available. So at the moment, we can test for 3 types of Stargardt disease. The most common form is an autosomal recessive form that is caused by variants in this gene called APCA4, this one at the top here. But then you have 2 dominant forms of Stargardt disease as well, which are caused by mutations in different genes or pathogenic variants in different genes. But with one panel, you cover all of these genes. So they are all looked at in the one single panel test. And here is an example of phenotypic heterogeneity of APCA4. So I told you in the previous slide that APCA4 variants, biallelic variants in both copies of APCA4 give you Stargardt disease. But biallelic variants in APCA4, different types of variants, can also give you fundus flavimaculatus, which is a much milder later onset form of Stargardt disease with less obvious retinal signs. You can also get a cone rod dystrophy, just a classical RP, or even a very severe, early onset severe retinal dystrophy-like presentation, almost like a Leber congenital amaurosis type of presentation. So it's the same gene, but different variants in the gene are giving you different phenotypes, and that's what phenotypic heterogeneity means. So I want to now just discuss a few scenarios where we have used different sort of panels to try and get a diagnosis. So this was a child that I saw in my clinic. She was a two-year-old girl. She was the first child to first cousin parents of Asian origin. Mom, when I saw the family in clinic, mom was already 28 weeks into her second pregnancy. But the family was they were quite certain that they wouldn't want to intervene in the pregnancy at all. So they were not basically seeking a diagnosis for prenatal testing. So the history was that this child, this two-year-old girl, had been born with post-axial polydactyly, so an extra digit on the medial aspect of your hands and on the lateral aspect of your feet, so on both hands and one foot. And those extra digits had been removed by the pediatric plastics team. This girl, already at 2 years old, at 2 years, was showing evidence of motor delay and speech delay. The other thing is that she had actually gained a lot of weight from the age of 1 year. So before 1 year, she was on the 11th centile for her weight. But when she came to see me, she was on the 99.6 centile. So she was gaining a lot of weight. And she was also under the care of the pediatric eye team because she had high myopia and she had prescription glasses for that. So when I saw her in clinic, I was struck by the fact that she had trimelic, 3-limb post-axial polydactyly. She had developmental delay. She was obese. Her BMI was greater than the 99.6 centile, and she had eye findings. And with this combination of clinical findings, I was fairly sure that she had Bardet-Biedl syndrome, which is an autosomal recessive ciliopathy. So at this point in time, I thought we should have a diagnosis for this child because this child is very likely to develop a retinal dystrophy as she gets older. She's likely to get kidney problems. She's likely to get other additional problems as she gets older. So we really need a diagnosis for her. Plus, we have a specialist, highly specialized clinic for pediatric Bardet-Biedl syndrome to which I could refer her, where she could be seen by an MDT, by a multidisciplinary team of specialists. So I had the option of either using a retinal dystrophy panel, which has the Bardet-Biedl genes on it, or the Bardet-Biedl syndrome panel, or I could just put her on a comprehensive ophthalmology panel. And when you're faced with these sort of decisions, if you're very certain of what your patient has, go for the narrowest panel. So the narrowest of the three panels was a Bardet-Biedl panel, which has 17 genes on it, whereas the comprehensive ophthalmology panel has 567 genes on it. So what that creates is when you look at more genes, you get more variants, more variants have to be classified. It takes longer. You get sidetracked by incidental findings. So there's a lot of noise. You'll get your answer, but you'll also get a lot of noise. But when you're very sure of what your patient has, it's better to go for the narrowest panel possible. So we actually tested her with the Bardet-Biedl syndrome panel, and sure enough, she was homozygous, as you can see here, for a BBS9 variant. Both parents were heterozygous, they were carriers. So the child had this variant in both copies of BBS9, parents had it in only one. And the variant was classified as along that chart that along the figure that Ashlyn showed you as being pathogenic, not likely pathogenic, but the highest level of proof that that is disease causing. So we had a diagnosis of Bardet-Biedl syndrome type 9 for this patient. By the time these results were available, the new baby had been born, and I saw her in clinic again when she was 4 months old. She was at 25% risk of BBS9 because she is, this is an autosomal recessive disorder. So this girl had not been born with any post-axial polydactyly like her sister. She had no features of Bardet-Biedl syndrome. We found that she was like her parents. She was a carrier. She was not affected, and that is not going to have any relevance for her health until and unless she is an adult and she's thinking about starting her own family. And even then, it's going to be much more significance if her partner and her were to be consanguineous, like cousins or so on and so forth. Here's another example. So this 54-year-old lady came to us with a 1-year history of progressive loss of vision in both eyes and worsening night blindness. And then she told us in clinic that she had actually had hearing loss from childhood. She had been diagnosed at the age of around 4. And then over the next few years, her hearing had actually worsened. And you can see here, this is her most recent audiogram showing quite severe to profound hearing loss in high frequencies. sort of moderate loss in the mid frequencies and less severe hearing loss in the low frequencies. On examination, she had reduced visual acuity. These are logMAR scores. Fundus examination showed bony spicules of pigmentation suggestive of retinitis pigmentosa, and she had an OCT which showed loss of photoreceptors on both sides. This was her history. So she was here. This is this lady. She had 7 children from 2 relationships. Her father had been similarly affected. He had been affected late. Her father's brother and mother were also affected. Her father had died, and her paternal grandmother had also died. So again, you have retinitis pigmentosa, but one of the reasons why this lady came to clinic was that she was very concerned about her children inheriting this condition. So in this situation, you know what the diagnosis is, but the lady is actually asking you a different question. She's asking you for a test for her children. So you have to do genetic testing. That is probably the best way to be sure of being able to offer her children a test. So what sort of panel would you offer here? So here the choices would be between the retinal dystrophy panel, which has around 287 genes on it, and the comprehensive ophthalmology panel, which has 567 genes on it. So I chose to go with the retinal disorders panel, and what that found was a variant, a heterozygous variant, so variant in one copy of the gene called TUB4B. And that was classified, again, along the picture that Ashton showed you as being a likely pathogenic variant, which means we are 90% sure that this is going to be the causative variant for this person's problem. And so the final diagnosis was autosomal dominant retinal degeneration and hearing loss. Now, it's very interesting that this lady has an arginine at position 390 changed to a tryptophan. When you look at the literature, this is a recently delineated entity. What has been reported in association with TUB4B previously is this condition, Leber congenital amaurosis with early onset deafness. So the lady did have early onset deafness, but she didn't have Leber's because she only developed her eye findings at the age in her 50s. So not like Leber's. So then when you look more deeply into why there is this difference, why there is this phenotypic heterogeneity, you see that if the arginine, there are 2 arginines, one at 391 in the polypeptide and one at 390. If the arginine at 390 gets affected and is converted to a tryptophan, then you get the late onset retinal degeneration, but the hearing loss you still get early on. But if the 391 arginine is affected, then you get a much more early onset form of retinal dystrophy with early onset deafness. So once we had this result, we were able to pass this information to the lady, and then her offspring was sent to us by their GPs for cascade testing. And then lastly, case 3 is this child who's a 16-year-old boy, but he actually had been diagnosed with microphthalmia with optic nerve coloboma when he was 4 years old, and he had no family history of similar problems. So microphthalmia, optic nerve coloboma, I decided to test him with the structural eye disease panel, which has around 185 genes on it. And interestingly, he was found to have a variant in PAX2. So PAX2 actually only causes one eye disorder, and that is papillorenal syndrome. So you have eye problems and you have renal problems. But the classification of the PAX2 variant, it was a missense variant, and isoleucine at 114 had been converted to a serine. It had been classified as a VUS, a variant of uncertain significance. So we had to do some more digging to find out what this meant. So we initially did some renal function tests for him, and in fact, he actually had chronic kidney disease stage 3A. We also did an ultrasound scan of his kidneys, which showed that he actually had relatively small kidneys, and some areas of the kidneys appeared echogenic. And then we tested both his parents, and neither of them carried it, although we didn't establish paternity and maternity. We just tested said parent, said dad, and said mom, and they didn't have the variant. With these results showing that there was also a renal phenotype and neither parent had it, and therefore it was a de novo variant, we were able to upgrade this variant to likely pathogenic, and we were able to make a final diagnosis of papillorenal syndrome. And that is actually quite important because this person may want to have um, a prenatal test when he is an adult and is thinking about starting his own family. And at that point now, we will be able to offer him and his future partner a very reliable prenatal test for papillorenal syndrome. I think that's probably the last slide. So thank you for listening, and we'd be happy to take any questions.
there are any questions, you can put them into the chat, and we will try our best. Give people a few minutes just in case. Yeah. You can also reach out and we can try and get back to you separately if there's nothing that comes to your mind straight away. You can go through the organizer and we can get back to you.
I can't actually see the chat.
Don't worry. Tara will put them into our chat and we can see them. I'll call them out if there's any that come up.
Oh, I can see it now, yeah.
Okay, it doesn't appear there's anything pressing that people need to ask. But,
all right, thank you very much.
Yeah, thank you so much. And thank you, Manish. That was really nice. And thank you for all the case studies as well. They were really interesting. So yeah, we look forward to hearing from anybody if they have any questions.
Thank you.
Thank you very much.
Thank you. Bye.